Calimera. So I'm going to, I know we have wonderful interpreters, but I'm going to be speaking in English. There are multiple reasons for that. I think it's the first and only time in my country that I speak in English, because with students we have to stick to Greek. And because it's quite big task, quite a big effort to when teaching, to have everything translated in Greek. Otherwise, it's quite unfair particularly to undergraduate students. So on the affiliations, I'm called dual affiliations. I'm with the University of Crete, with the medical school, the clinical, social, and family medicine, and I'm also health services research in Maastricht. And in terms of background, I think there's quite a lot of information given we were asked to provide. So for me, I was lucky or unfortunate or fortunate enough to have seen systems and things and even disciplines from different prisms. So what I will be saying is, of course, my own experience and perspective. Although I have to say that the task I was given by Dimitra and John, and thank you very much for the kind invite and for organizing this, because we've been discussing it for a few years, is to set the stage for the rest of discussions and for the meaning of interpreting, potentially also translation in healthcare settings, and also social care, I think. And I will say something about that. So you have to forgive me, because normally my decks are not so dense. This is a relatively dense deck. And also because there will be a lot of terms and notions and concepts which may be very simple, same as crisis, but which the interpretative framework anybody or everybody applies is quite different. Before I start, we wanted to have an interactive element, because in workshops we always try as a department in Crete to have people engaged. And to the previous question of Miss Apostolou, yes, I thought this was very interesting, because I could hear the passion in the voice, and I'm sure that pertains to own experiences and narratives. And that is very interesting, we found, because if you open the space and the panel and the people come engaged, it's a learning experience for us too, as speakers or teachers, and it's better to study systems and, if you like, fix things in the long run. But the format of today is audience sitting and me up here, so it's not the best for interaction. Nevertheless, if you go to this link, this is to give me an overview of what you have had exposure on and what you have been offered. If you go to this link, you do not need to create an account or anything else. You just select student login, and then when you ask for a room name, you put my surname. And then you will have 3 very simple questions. The first one pertains to whether you have had exposure or you have worked in a crisis setting, independently of what you may be involved in. Whether you are a translator or an interpreter or, I don't know, healthcare professional. The second one pertains also to the crisis setting, and I have put a note saying use your own interpretation of that term, not what I will be showing. And the third one pertains to what has been available to you in terms of support or formal training. And again, this is for us. It's anonymous. I think I've set it correctly for you to be able to see the total output. And I will also try and see it in my mobile, so before we start interactive element of dialogue afterwards, and follow up after the workshop. So if we can go to my presentation. I think it's better if I do it, actually. Do you want to give me the mouse? Yes. Thank you. Yes. So, oh, that's very different from what I see. Yes, I think you need to really, the contrast has to change, or we switch off the lights completely. Yeah, it's better. So this is the definition of crisis, which you can find in the World Health Organization's vocabulary or glossary setting. It comes from the Oxford Pocketbook Dictionary, and as you can see, it's pretty broad in the sense of any situation can be considered to be a crisis on the basis of very specific modifiers. And there are different layers or levels or descriptors for this. And conceptually, it can cover a very wide spectrum of things, from preparedness to response. And I'm sure you all have heard the term crisis management. It can also be a time of danger or simply a time of greater difficulty. So crisis or crisis is a term used with a very wide spectrum of descriptors. This is a very different term. It's emergency.
I think you need to move closer to the microphone.
Oh.
Some people can't hear.
Can you hear me now? Yes, okay. Thank you. So emergency is a wider term. This is a definition coming out from the CDC Handbook of Handling a Crisis, and for me as a public health specialist and professional is a key handbook to have, because it pertains to communication not so much as one-to-one, but more to how you handle a crisis, how an organization speaks to the public or speaks to a vulnerable group, moving pretty much as described before by Boris. So interestingly enough, I mean, when we talk about crisis and emergency and preparedness in public health, we don't automatically think traditionally of refugees and migrants. We think of biohazard issues, we think of terrorism, of course, but I think you will find that the two terms are quite interesting. What I want you to think, looking at the next slide, is traditionally. We have a very long tradition of interpreting, I think, as a nation or as Greeks or going back to Dragomans and so on. Any situation, any moment in time, any given moment in time can turn into a crisis. This can happen because of geopolitical events or because of lack of resources or because somebody is experiencing a sudden onset of disease or death or something else. And what is important to think is that the characteristics of an emergency situation, sorry, I forgot to change the slide there. So the characteristics of an emergency situation may be clear enough in terms of describing it, but may not be so perceptible to an audience or to an untrained eye. Also, the setting may be defined differently by different people. And I think if you're talking about an interpreter to a king being healthy versus an interpreter to a king with a foreign doctor being ill, you have a good example of how things may change. For medical perspective, all the tradition we have on communication and shared decision making and so on comes mainly from oncology. But in the last 20 or 30 years, it has gone across a wider spectrum of discussions. Very characteristic example, because I'm adjunct faculty also at the midwifery department, is when we have strange findings or loss of heartbeat in an ultrasound or echo test for a young mother to be. And then you have the loss of life to announce, and you may or may not have an interpreter, and you may or may not have facial expressions showing on the face of a technician. So what I'm trying to say, and I would like you to keep that in mind, is that the crisis is very heavily immersed in a discussion for refugees, for austerity and so on. But really, if you really think about it, particularly in healthcare, crisis potentially is any particular moment in time. And also for the migrants and refugees, absolutely, it's here to stay. I'm not so sure it's one country's issue. Let's see. Yeah. Let's go back. Can I go back? Thanks. So yes. So again, I'm sorry, I forgot to change. This is quite difficult. Maybe pull it here. So yes, again, so we have cancer and we have combined effect of other factors. And there is also something additional to consider, the people involved in a situation, what they may have experienced, what their capacity may be, and what their intent may be. And this last part is not always so very clear, because we assume that everybody has the same intent in terms of communication. That is not always the case. So in terms of conditions, we have issues on code of ethics and issues on interpreting legislative frames. We do have rules and regulations and the interpreting thereof, not in terms of linguistic only aspects, but in terms of what they mean for us, in terms of rights and obligations. And we also have referrals. I don't know how visible it is from the audience. From here it's rather pale, but that's from the Greek interpreter. That's a story in Sherlock Holmes where an interpreter is found in a very difficult position of having to interpret for somebody who is obviously under duress, is abducted, he's disfigured, there's threat, there's different pressures. So again, these things can happen rather suddenly. What is very rarely discussed in healthcare settings, I think hardly ever systematically so far up to now, is the effect on the interpreter or mediator. I'm not going to use cultural and intercultural because that's another discussion, massive, in some quarters. But we have never really systematically looked at the impact of the mediator, of the person attempting to communicate or make communication possible between two people. So I would like to go now a little bit into more of our own medical, if you like, things. So there's a multitude of settings, there's a multitude of circumstances, and there's a multitude of needs. So historically, it is for the last, 20, 30 years, we have had evidence-based medicine emerging very strongly, and shared decision-making being a critical component. So it's not a question of it would be nice to have, it is critical to have for quality of care and for outcomes. We have evidence, we have now thousands of studies showing that. But shared decision-making implies very clear, very explicit, very trustworthy communication between at least two parties, ideally more, because we have interdisciplinary teams. What people, and also my students very often, when we discuss means of communication, do not realize is that when you're taking down narratives, when you're taking down history, when you're documenting an effect, you really are participating in an activity which is for communication and communication. And anything from jotting down adherence to medication regimen or questions about the preferences of a patient or of a person, because we don't always have patients, we also have persons which are not suffering but which are in a preventive program or they are carers of other people. You really need to consider all aspects of communication. I have put it in red because I think this is also very rarely discussed. We discussed a lot in clinical trials because I spent 15, 20 years in clinical R&D. Consent is implied very often or asked and given with very little understanding of what is given, but implicitly in legislation, in ethics, everywhere, consent has to be an informed act. And this is something that pretty much everyone often takes for granted or does not quite think about, but consent implies communication has taken place, and communication has to be really 100%. I often give examples. I don't think people realize that you go to give blood, nobody's going to tell you every single possible side effect you may experience, like redness or swelling on the side. But implicitly is implied that you have agreed to potential side effects like that manifesting. Things of consenting are not always so clear. I do not know if there's another speaker to speak about that. But often enough, when you have a discussion which may decide the life or death or whether you will be embarking on surgery or whether you will be embarking or a very difficult treatment, I don't think so, because I'm counting here and I've spoken for 9 minutes. Okay, so this is counting, so don't worry. Yeah, so it's very difficult to see and to understand how consent is taken and given. I will say that we lack formal training systematically in the healthcare professions. I think interpreting professions and translators even less. Okay, so we've looked a little bit at how much communication is needed. There's hardly any interdisciplinary training, certainly not with interpreters in a healthcare team in any setting. We do have a lot of informal interpreting. That's worse. And I'm not talking refugees and migrants now. I'm talking pretty safe, high quality, very developed country settings. And to go a little bit faster, yeah. going to this, for intercultural mediation to becoming a member of the care team, it's becoming acknowledged, it's necessary, and there's a need to eliminate and compensate for the adverse effect of barriers. This is not so clear because people, when we say, we're going to bring a mediator on board, people say we need a translator. And of course, it's a completely different thing to an interpreter, but this is not the perception of a healthcare team because they're not trained in that. When we have migrants or refugees or asylum seekers or MEMS, we have different terms. You need to also consider that you need to have an interpreter or a mediator compensating for the disparity that is being experienced in access. So he has a ladder effect. He has extra things to do as well as minimum intervention and safeguarding the autonomy of the person. Now, this is, very quickly, this is a guideline on patients. It came out in NHS in 2012. It's a beautiful guideline. It has 3 critical points on communication and 3 critical points on communicating with different tools. It also has one beautiful point, which I will show, although it's very technical, just to give you an idea, on benefit risk. And benefit risk is critical for anything, from Nurofen to a surgery. The clinical guideline has been there. It's critical for shared decision making. And theoretically, the guideline has, 50, 60 points. There are 3 pertaining to communication. The question is, what has been the output of that? And the output of that has been nothing, because not a single one of these points has ever been measured for this particular guideline. And this is England and Scotland, and well, Scotland doesn't have this particular one, but this is NHS and NICE, so it doesn't get any better in terms of universal coverage. So you would expect, and quality assurance, you would expect that they would, but they haven't. And there are very practical reasons for that. So implementation of a guideline is only as good, or a guideline is only as good as its implementation. And there are different reasons for not doing that, which pertain to cost and to resourcing and to facilitators. And certainly to collect that kind of information, you need to involve interdisciplinary teams and interpreters and so on. And interpreters sporadically are even given a number. So they're not part of a system or a continuum. They may change or fluctuate, not in refugee setting or migrant setting, but even in a normal setting. If a patient continuously visits a team, has 10 encounters over a 2-year period, he may have a different interpreter each and every time. So building a trust relationship and knowing whom you're handling, it's not so easy, even in the best possible resourcing schemes, let alone in depleted resources settings. So I hope that somebody would speak about that later on, because this is the World Health Assembly, the WHA resolution, that says that we have to spend money on that and we have to make an effort of that because it's equitable access. I will skim through it very quickly. So these are the Sustainable Development Goals. I hope you know them. If not, you should, because they pertain to every single one of us. And they also safeguard our access to UHC, which is endorsed by all countries. And this has been in place now for a long time. The SDGs have been there for a couple of years with indicators. And 3 and 6 and many others. Let's see. No, I need to go back. Yeah, it's okay. All discuss getting all of this quality and essential healthcare services to everyone. You cannot do that without having appropriate communication, mediators, and so on. There's little discussion in Europe. Let's see, yes. So there's little discussion in Europe on challenges systematically, although they're emerging. So we're starting to see some training programs here and there, but they are not, if you like, coordinated centrally or systematically, and there are different barriers besides the resource limitations mentioned, besides the potential cross-border impediments which have to do with visas and a person coming, from Syria to train in Greece, but not being able to go in an exchange in Germany and so on. Germany has a lot of problems as well, as I was there for 5 years. And there's more than that, because across the healthcare settings of different countries, even from local to regional level, even from Athens to Crete, even from Berlin to Frankfurt, Frankfurt suburbs and Heidelberg suburbs are very different to Berlin. The paradigm of care, how doctors and healthcare teams interact with people, and I'm saying people, not patients, but okay, patients of course too, are very, very different. and some systems are not so open to taking on board the patient's perspective or the person's perspective. So even if the interpreter is well equipped in terms of knowing principles of SDM or shared decision making or consenting and so on, they may have other difficulties in implementing a uniform approach across Europe. And this is why professionalization is so key. You need to build a network of yourselves to support each other. So we discussed a little bit on communication barriers. I would like to stay on this point and then talk a little bit about projects, and I think then we wrap up, but I have another 6 minutes according to this. So, 16. Dimitri said 20. So bear with me for 2 minutes. So we have seen two things: pragmatic approaches, which were usually ad hoc because of the crisis, and formalized approaches. One would say that the main part of the crisis, or what was experienced in Europe, passed because it was 2015, 2016, and so on, and the migrant flows are stabilizing. That is not necessarily the case, because there are different regions and different places where you have to deal still with many people in local settings, and this is why I found the comment by the first member of the audience so interesting. The ad hoc responses, which are not formal, cannot have quality assurance. They cannot assess damage done. It's impossible to assess clinical, social, and ethical potential ramifications. And of course, if somebody is volunteering, it could be even a relative. You cannot take them, legally. There cannot be ramifications or control or take them and assess what they have done. And we do have evidence that the formalized approaches work much better from North Africa. This also comes from UNHCR, I think. But we don't have yet the consistent approach for WHO Europe region. So anyway, there are some things on compassionate care very quickly. Don't have much time, but what I wanted to say is that this is a key concept for us, compassionate care. Let's see. Hope the slides will be available. Okay. So the interactive element we discussed before is this. And I do not know how many of you know what compassion fatigue is or why it's critical. Burnout was acknowledged a couple of weeks ago as a disease by WHO, and that's good news. What people do not know is that compassion fatigue has rapid onset and may lead to apathy and may lead to very even violent feelings towards other people. And burnout takes time, but it's very difficult to recognize if you're not trained in it. And I think for interpreters, I haven't seen any systematic ever training anywhere for it. And I think it's very much needed. I think it's needed also for doctors and medical teams and students and really everyone, but it just wasn't there up to now. Okay, so self-compassion and self-care is that notion that builds resilience. And all of this knowledge, may sound very reasonable, but one may wonder where we got it from. So very, very quickly, we were running way before the crisis started a key project, Restore, which has also been used by different international bodies, which looked at cross-cultural consultations. Our interest was not interpreters at the time. Our interest was how does a very educated foreign physician visiting a country may talk to a Roma person or may talk to somebody who has a low health literacy level. But the message was consistent and it was the same. You really need to assess competency versus fluency. These are not the same thing, and fluency often is considered to be adequate. That is not practically the same in terms of outcomes. Okay, and then we did two rather big, or very big, capacity building programs. I need to go one back. We're almost done. Yeah. So you can actually measure compassion. You can teach compassion. There is some information on what we did in Human and in Orama. I do not know if you know the programs. They both were cross-border, European, and quite large, same as Restore, but they were not research programs. They were capacity-building efforts, rapid capacity-building efforts, and the effort to have meaningful output for longer term is very difficult when you're being funded only for capacity building. Okay, nevertheless, it is measurable, it is teachable. And there's plenty of papers for reference if anybody is interested. Let's see. I think we have one more slide and we're done. So this is what's happening now and what you can hope to have in the next a few months, not only from academia and the medical community, but also I think from WHO Europe. What we have is we have had the first one is from Hans Verep, who very kindly confirmed that we also have this in Slovenian, is the Guide of the Federal Public Service of Belgium for cultural, intercultural really communication. It's in its third version. There is already a HEN report of last year on communication barriers. What is new, what is happening now is on the 2nd of July, we have a new HEN report. That's an evidence in thesis report being released and presented, and the webinar is open to anyone, so you can actually see it, see what they propose for the profile of the intercultural mediator. And there's a lot of work behind that and a lot of research projects, and I hope that in the future FIT will be on board discussions for that, because we need more multidisciplinary discussions. And this is my personal opinion, but feel free to disregard it. I think it would be useful to stick with key concepts beyond crisis and beyond migrants and refugees, which are, without a doubt, critical components. Access and literacy and rights-based approach and people-centered care and shared decision-making and consent are enshrined, if not yet in legislation, definitely in resolutions, which are a start in terms of policy making. And there's ample evidence and other things that you can read on why it's important to have very open multi-stakeholder dialogue about them, and why you should be part of this dialogue, which is also an actionable item on your side. That's it for me. Thanks for bearing with me on the extra time. And yesterday was World Refugee Day, and I think that goes without saying that we support that intensely. So we do with UHC, with universal health coverage. 3.8 is leave no one behind. That's certainly refugees and migrants. And thank you.